Time for a Chat provides the concise yet comprehensive information on the highly prevalent issue of ineffective communication in healthcare system. The book is a winner of 2013 Human Rights Literature Award and is written by an oncologist and renowned author Dr. Ranjana Srivastava, currently practicing in Melbourne Public Hospital. Other books written by Dr. Ranjana Srivastava include A Cancer Companion and Tell Me the Truth. The author, by using her vast experience of working in health system, has made an attempt to draw the attention on the imperative but consistently overlooked issue of ineffective communication that not only undermines the well-being of the patient but also contributes to the issues facing Australian healthcare system. Thus, the book accentuates on the need to address the communication gap to utilize the advancements in medical science in a best possible manner to achieve better outcomes and to ensure the sustainability of health services. The author has centered the text on a 90-year-old female, Mrs. Johnson, to discuss multiple issues in healthcare system impacting the quality as well as the outcome of the treatment provided to the patients. The author has very nicely explained the lack of communication skills in medical professionals by thoroughly describing the avoidable sufferings which Mrs. Johnson underwent due to multiple communication errors. To start with, poor communication between different specialists lead to Mrs. Johnson's renal failure. Although the author was aware of the probability of worsening of Mrs. Johnson's condition from the beginning, but no one had the time to discuss this important matter with her, and the matter seemed trivial as she was showing the signs of recovery. Even on worsening of her symptoms, everyone, including the author, chose the easy way out by avoiding the discussion about end-of-life care and with the patient or her daughters. Furthermore, options were presented to her daughters as the ray of hope, but the discomfort associated with the procedures and the inevitable outcome were omitted from the discussion, leading to futile decision making by daughters on the behalf of their mother, adding further suffering for her. The author has argued communication issues result from lack of training and inexperience in such situations. Wu et al. Has also documented that clinicians treating patients at end of life usually lack adequate training to help them in making end-of-life decisions and to inform the patients about undesirable outcomes. A survey conducted by Sullivan et al. Showed that 18% of medical students and residents received formal training in end-of-life care, and over 40% of residents felt unprepared to teach end-of-life care to the younger clinicians. The author has also highlighted the issue that most often doctors believe that they have provided the sufficient information to the patient, but the patient feels unsatisfied with the explanation. Studies on the doctor-patient communication have shown dissatisfaction among patients even when the doctors consider the communication was excellent. Tang et al. Has provided that while 75% of the surgeons were satisfied for their communication with the patient, only 21% of their patients were satisfied. The author has also touched upon the issue that diagnostic aids are being used for more often to establish a diagnosis rather than detailed conversation with the patient about their symptoms. Yan et al. Has reported that physicians favor to use the available aids and rely on the contemporary trends to manage an illness rather than discussing symptoms with the patient. The author has also highlighted the issue that the higher remuneration of specialists and the misperception that specialization represents greater achievement lead to increasing number of specialists. The specialization in a particular field results in fragmented approach due to lack of financial incentives. General practice has become a site for quick fix as patients suffering from multiple diseases get referred to multiple specialists. Each specialist looks for narrowly at a particular aspect but critically lacks overall picture. This results in negative impact on the well-being of the patient. Mrs. Johnson's death illustrates this issue as she died from a renal failure caused by adverse interactions between drugs prescribed by different specialists without knowing the treatment provided by other specialists. Moreover, specialist consultation increases the chances of expensive procedures and interventions to be conducted, which can be futile at times and even adversely impact the patient health. The author has given an example of how a futile CT scan ordered by a lung specialist to find a more specific cause of exertional dyspnea in an overweight patient, but which commenced a series of miserable events, ending in a transition of patient in a nursing home. Similarly, a futile MRI triggered a series of events resulting in the passing away of a confused patient. Thus, author, by citing the Dartmouth et al. Study, has also documented that patients who receive more intensive care do not necessarily suffer more complex or severe illness, do not necessarily receive evidence-based care, and do not necessarily have a better outcome of the treatment. In line with the author's argument, Strange has also highlighted the ineffectiveness of technologically advanced US healthcare system attributed to fragmentation. Strange has also highlighted the increasing specialization also impacts on the goods made by manufacturers, as they are more inclined to make highly profitable goods rather than those which yield lesser benefits, contributing to the inequality in healthcare services. Lee has also documented that fragmentation, along with lack of communication and coordination between teams of specialists, raises the concerns about patient safety. By being skeptic about Mrs. Johnson's admission to ICU, the author has raised the issue of suboptimal implementation of evidence-based best practice guidelines while treating the patients. Such an approach may result from legal obligations or due to financial incentives, as denying intensive care to a dying patient can invite lawsuit, and rejecting to prescribe antibiotics to a patient with viral sinusitis may result in patient seeking treatment from another physician. The core issue playing part in this problem is patients' linear understanding of the medical services or treatments. For them, sickest patients go to intensive care because it is the place that fixes them, and antibiotics are given to treat the infections. Abundance of dubious information on the internet influences the patient perception about health and persuades them to seek specialist consultation or to seek for an expensive but futile treatment process. Thus, the author has recommended the implementing patient-centered care, including the support for patients to enable them better understand the disease outcome difference in different patients. The author, while describing most of the above mentioned issues, including increasing specialization over investigation, medication use of futile importance, legal obligations, and ineffective communication, has explained how they exert extra pressure on the healthcare due to wastage of resources, including time and money. The author has also shown her concerns about aging population, and by citing Australian Institute of Health and Welfare, she has documented that aging population will face a glut of complex and chronic diseases in the next 20 years. Thus, to ensure the sustainability of the service system and the quality of the services delivered, urgent measures required to be implemented to prevent overusage of health system. In the end, author emphasizes on the need to understand that poor communication between doctors and patient is one of the primary drivers of dissatisfaction with healthcare. Dr. Srivastava has emphasized that best medicine should begin with chat, and to obtain this, she has recommended formal training of health professionals. By giving the example of Boxbaum Institute of Clinical Excellence and New York's Memorial Sloan Kettering Cancer Center, the author has advocated to train clinicians for becoming navigators, advisors, and counselors to facilitate patients in the difficult decision making. She has also recommended the use of feedbacks from patients on different styles of communication to train doctors on the way to share the information in a best possible manner. The author, by citing Schwartz Center rounds, has also acknowledged the importance of relieving the stress and isolation of the health professionals in improving their ability to communicate effectively. The author has also advocated use of checklist for the health professionals to help them consider the right time and right place for the conversation with patient or their family members, and to be compassionate and to share information properly, and to invite or entertain the questions put forward by the patient or their family members. Thus, Dying for a Chat book expounds on how objectively efficient healthcare system is failing on the subjective grounds. Ineffective communication is leading to the death of the patients, dissatisfaction in community, disheartening of the doctors, and disapproval among bureaucrats. Though training health professionals on communication techniques seems trivial, but it has the potential to improve the doctor-patient relationship and their involvement in shared decision making. By reviewing this book from the lens of a public health practitioner, I would agree with the author that the health system is more focused on preventing the inevitable death than improving the quality of life. Terminally ill patients do not want to live longer, they just want to die in comfort. The relatives would like to be aware of the possible outcome beforehand rather than being surprised. The strategies to strengthen the doctor-patient relationship and to make the communication more effective, as suggested by the author, are seemingly by far the best possible solution to address the discussed issues. But I wonder how much role does the increasing social isolation plays in the misery of end of life period. Does spending more time with loved ones will help to understand in a better way that what they actually want in the end stages of their life and facilitate the decision making it more easier rather than a third person which may have been known to them for a few hours or days describing the available options and putting forward the clinical aspect of the situation. Thank you.